Good afternoon, everyone. Very exciting to see many of you joining us today in this very interesting webinar. I'm Punita Krishnan. I'm a physician here in Hospice Malaysia, and I will be your host for today. It's my great pleasure to introduce our speaker for today, Professor Peter Martin. He is a professor of clinical communication and end-of-life care at Deakin University, Australia, where he also served as the director of Center of Organizational Change in Person-Centered Healthcare. Additionally, he is also practicing palliative medicine. With over 30 years of experience in communication skills training, Professor Martin has contributed to numerous medical schools and postgraduate courses across the country. So I believe his wealth of expertise and experience will provide invaluable information that will help us all today. So without further ado, please warmly welcome Professor Martin.
Thank you very much, Preeta, and thank you to Hospice Malaysia for organising this and inviting me to speak to you. I'll just get my slides up to make sure there's no other technical issues, so just bear with me 1 second. And hopefully, is that slide view up? Yeah?
Yep.
Yes.
Thank you. All right, so what I would like to do tonight is to cover a broad brush of healthcare communication research and evidence, as well as my own reflections as a palliative care clinician, which I'll get to in a minute. I've also got an appointment in Denmark with a unit that does very similar work, working with in the postgraduate workforce space, and we go there at least once or twice a year. So what I really want to talk about is the impact of the quality of the care we give based on how skilled our conversations or our communication is. I've got my Twitter handle, even though I don't use Twitter so much, but I'm on LinkedIn as well. So let's see if this... the first thing I want to say just is that I have an interest in cancer cachexia research and have published in that. But when I really think about my own professional development, all the things that have really stretched me have been how to have skilled conversations. And in the cachexia service that I ran and led for 20 years, it was about helping people exercise and change their nutrition and other things when they're feeling fatigued, etc., etc. So I've got that view as a kind of researcher, as a clinician, and as a director of clinical services in a number of organisations, both in Australia and the UK. I just want to talk about this organisation where we have chosen to go out and work with health professionals in the kind of workforce. And just in the last 5 years, myself and my colleagues have trained 5,000 people in the nursing, medicine, allied health, and indeed non-clinical staff as well, mostly in the state of Victoria here in Australia, but also overseas and interstate. I just wanted to outline about what I wanted to cover tonight. I want to talk about the big picture of healthcare communication in general, then go to some very specific topics like prognostic discordance, which I'll explain in a few minutes. The place of strong emotions, both for patients, families, and colleagues. Obviously, then some other specific issues regarding life-limiting illness. And then lastly, a little bit on how we talk and how we communicate, impacting on how we work as a team and our future workforce, including the thorny issue of burnout. So the thing I want to really say is that all of you as palliative care clinicians are the hidden curriculum. In other words, we've got a curriculum about teaching analgesia or how to treat nausea, etc., etc. But what we often don't think about is that people who are watching us about how we communicate, whether that's with patients, carers or family and colleagues. And some of my international colleagues say this is our procedure. In other words, the very specific skill that we must have as palliative care clinicians is to have excellence in our communication, because we're being watched. And if we don't do it right, then what hope really do we have? And I would push you one step beyond that. not only must we be able to do it, we must be able to teach it. And I'll come back to some of the issues, because people don't always learn by just observing, particularly people who find this difficult. They don't know what it is we do that makes things skilled. So some key principles: it's a skill that needs to be taught, just like driving a car or doing a laparoscopic cholecystectomy. It needs to be practiced, taught. There is at least 50 years of evidence, depending on how you define it. And a lot of the evidence is actually quite high level evidence. If you actually want clinicians to acquire and refine skills and confidently change the behavior, you need to do that through experiential techniques combined with theory and frameworks like we're doing tonight. And what I'd really like to convey to you is that you must be able to deconstruct conversations into little micro bits to teach it. There's no point just saying, watch what I do, and hoping they pick it up. That is very hit and miss, and the evidence is very clear about that. I would suggest to you that everything you do is based on skilled communication. And I'm going to show you some evidence about that. And skilled communicators choose, combine, and sequence what I'll call micro skills, which I'll show you in a minute, depending on the context and the person in front of them, including of what they perceive. So if we go back to some bigger themes, there's this whole issue that right across the world, our community is demanding that they be treated as an individual, just not another kind of cog in the machine. We particularly know that people moving between parts of care, clinical transitions, particularly out of acute hospitals, is not effective. People want to say in their care, and that we know from the evidence, and there's hundreds of papers, that is very variable. And increasingly across the world, there's a concern that we're burdening people with unwanted low-value care that's not concordant with their wishes. And just to give you an example of that, this has been replicated in many countries. If you go into most acute hospitals in developed nations, about a third of the people in those hospitals have a life-limiting illness. And if you follow that third for 1 year, half of them are dead. And if you follow that third with a life-limiting illness for 3 years, 75% of them have died. And I guess what we're seeing in acute services, they're fixing up the problem in front of them, but not thinking of the big picture. And increasingly, we're seeing people not coming in with one problem, but a combination of comorbidity with multiple problems and clinical constructs such as frailty. And in fact, they have looked at frailty alone as a single big predictor that people do not consider what that means for their prognosis and their care. I'm not going to touch too much on overdiagnosis. This is this issue of people just doing scans because they can and turning well people into potentially unwell people. It's a quite contentious issue, but there's a lot of very good research about the concern about overdiagnosis. So I want you to just briefly take a few seconds to think, if you were talking to somebody in the community about how they would describe what it's like to be in our health system, just think of a single word. And what I've done is just put a few of those words down from the literature right around the world. And what they describe the care as being fragmented, transactional, and I'll come back to that term in a minute. Generic, they feel they're just being treated as the next person with lung cancer or the next person with kidney failure, etc. And that they often feel rushed, and I'll come back to the perception of time rather than the actual time. This has made some authors, and in fact, right across disciplines, very concerned that healthcare is being industrialized, and that even in countries that are, if you like, emerging into a more developed system, that the first mistake they make is to industrialize the care, to treat people as just a problem to be pushed through as rapidly as possible. And I know we don't want that in palliative care. So on the left here, I hope you can see this. This is where all the consumer groups in the UK got together, National Voices. And the two reports on the right, in the middle and the right, were from a survey in Ireland where they surveyed everybody who left hospital. And what they found is they all wanted the same thing. They wanted us, the clinical teams, to listen more and talk less. And they felt unsafe leaving hospital. These key transitions when they've been ill and they need to return home to their families, they did not feel they had the information they needed to be safe. And they're repeating this survey. And as I said, this is a very consistent picture internationally. So here's a big study in cancer across 10 countries, not including Asia, sadly. But what I wanted to say is that nearly half the people who got diagnosed with cancer didn't feel they had any say in the care that or the treatment they received. They felt it was all biologically focused and did not take into consideration their own unique family or other personal issues. So this consensus group got together. This is our kind of one of our landmark journals that are published regarding communication called, it's got a terrible name, Patient Education and Counselling. But this was a very big consensus statement about getting the humanity back in healthcare. And what they want said, if I can kind of summarize the article, is that we need to refocus on connecting back as humans, moving beyond this kind of construct of just simple rapport, be very respectful, to understand what's important to the patient, and throughout the whole interaction we have with patients and family, to recognize that they will have a huge variation in emotions that they're experiencing, and that we need to tailor or customize or personalize the care based on what's unique to them, their family situation, their finances, their culture, their belief systems. I would encourage you to read this article. And so our community feel that they're getting fragmented care where they're passed one person to the next without continuity. They feel that we're not forming relationships and they're just a transaction to be treated, and they feel they're just another diagnosis to be treated the same way rather than individualized care. So I think we really need to think if this is what our community is telling us, how can we change it? So some C's of communication. There is a lot of work internationally that you need to maintain your curiosity. Once you've lost your curiosity, it is very hard to give person-centered or compassionate care. We know avoidance is a real issue, that people avoid difficult conversations. And so you need to be confident that you can have them and therefore have the courage to bring up difficult topics, whether that's prognosis, whether it's existential issues, or whether it's a discordance between what you think is optimal for their care and what they may be asking. And if you go back to Aristotle, the great educator, he talked about this idea of choice, not chance. And so this idea of considered communication, that you can think in the moment how you should proceed, what you should say to these individuals. And that all brings the issue of core competence. We want people to be competent in things like prescribing complex analgesia, obviously, and a whole range of others. And I think we need to think about the competence of the core communication skills. And my personal view is that palliative care clinicians need very advanced skills, not only to kind of provide clinical care, but to teach and model for others. And all of that drives culture change. I was asked to speak some years ago about the art of communication versus the science. So I want to break it up in my opinion, which of course is the lowest form of evidence, is that the science is for many domains, health education, business. In fact, there's lots of really good information about communication in neurobiology and even primatology, how we're all, as primates, kind of built, if you like. There are linguists, there are behavioral scientists, there are comm skills researchers, there's high fidelity simulation, and there's human factors. And I think we need to bring them all together when we're caring for our patients, families, and how we're interacting with our colleagues. And my view is the art is how we used evidence-based skills while maintaining your authentic self, being your authentic self. So you don't sound like the next person, that you really are bringing that humanity, your own humanity, into care. Now, here's the elephant in the room. The first thing clinicians say is, that would be lovely if I had enough time. And in general, palliative care often has more time than many of our colleagues. But in fact, that's the biggest concern for many clinicians. I don't have time to give person-centered communication. Well, the evidence is starkly in contrast to that. That in fact, as you become more skilled, you not only become more effective, more person-centered, but you become more efficient. And if you see a really skilled communicator, they often look as if they've got all the time in the world for the patient. And these are three key skills I just want to highlight from the evidence that make you much more time efficient. The one I'd like to highlight most is if at the start of a consultation you say, we've now got 20 minutes together, this is what I'd like to cover, what would you like to cover? And then you need to negotiate that agenda. That's probably the single biggest missed opportunity for time efficient person-centered care. We know that if you invest in building rapport and trust right at the start, they disclose more, which means you can get to the heart of the matter much more quickly. And probably most counterintuitively, clinicians who are good at spotting verbal and non-verbal cues and addressing them speed up. And I'll come back to some research about that. They speed up consultations and get to the core much more quickly. So productivity, there's two aspects of that. The study on the right got oncologists to incorporate goals of care discussions, and the oncologists were concerned about the productivity. And this, among many other studies, showed if you get professional development training, it does not affect your productivity. And on the left, this is a study to show not only that, but actually if you have these discussions, it lowers healthcare costs. And I can show you some other data about that. What about the impact on the consumer? And again, just take 10 or 20 seconds to think, what do you know from the evidence? Because I'm sure you all know evidence about analgesia and antiemetics, etc. What about the evidence of how we talk to people, the impact on their care and their health? And I'm just kind of going to show a summary document. So think about what's the impact for the clinician, what's the impact for the patient and the family, and what's the impact for our health system. And here's a summary slide. What we know is that your communication skill, how you talk to people is linked to diagnostic accuracy. And there are particular issues around these concepts of premature closure or confirmation bias, meaning if you just read what your colleague has said and don't check it out, you may suffer from confirmation bias. We know that skilled communicators can have much more advanced clinical reasoning because they've got the right data to look at the patterns. A massive issue is that the figures vary a little bit, but about 50% of all adherence is based on how much they trust you. So you can be the smartest clinician with the best care plan in the world, but if they don't trust you, they will not adhere to your treatment plan. And the link with that is, of course, if they can't recall or understand what you say, they're not going to take it as well, or they might not take it appropriately. And I'll get back to safety. You may not think in Pal Care that you're talking about lifestyle modification, but of course we are. We're talking about how to mobilize differently, how to refocus their nutrition, how they might exercise, how they might modify their work. So there's a lot of lifestyle modification in Pal Care too, as well as those chronic non-communicable diseases. There is a bunch of very good data, particularly in diabetes, that how we talk to people actually has physiological outcomes. In other words, their glycemic control, their blood pressure control. And in fact, HIV and AIDS medicine is the other area where we know that even things like viral loads are determined by the relationship and how we talk to the patients. And about a quarter of all major adverse events where there's a major impact on the patient are due to how we talk to each other. On the illness side, I'll come back to this disease illness model. People want to be treated as an individual with their individual circumstances. They do not want to feel rushed. And of course, when we communicate about risk, that's not just about things like surgery or chemotherapy or immunotherapy. It's like taking an opioid. And in fact, I just read a paper today, just released this month, to show that PAL care clinicians talk about the impact and pain, but not the adverse effects of opioids. We tend to focus on the positive without feeling confident about how to discuss about side effects and adverse effects. This idea of talking about non-beneficial or non-goal concordant treatment, particularly around people with life-limiting illnesses. And massively, we know about how we talk to them has a huge impact on their psychological well-being, including severe anxiety and severe depression. And again, I'm going to show you a study on that. I quickly want to talk about disadvantaged cohorts. I've been lucky enough to be visiting Malaysia about 15 times over the years to see friends. And like in Australia, there are advantaged and disadvantaged cohorts. And I'm just going to quickly show a slide from Scotland, but I really want to say to you that, in fact, our communication becomes even more important if we're going to close the gap between the most advantaged in our society and the most disadvantaged. And you will know who they are in your own part of the world much better than I. But how you talk to them, how you give them an opportunity to talk, or agency, some people talk about, or empowerment, is so important to closing this gap. And so here is a study from Scotland, again, which I encourage you to read, called Realistic Medicine. And it's not just about the life expectancy gap between the advantaged and disadvantaged, but health. And I would suggest to you this is just as relevant in palliative care, where we know for things like getting good pain relief, there's a gap between the most advantaged and the most disadvantaged, often because of constructs like health literacy, etc. So how do we help people remember and recall, and therefore empower them to have choice in their own care? Well, the first thing to remember, and again, I could have put up many different studies here, is that people forget an awful lot immediately. And I'm going to talk about some of the approaches to change that. That half of what they do recall is often inaccurate. And here's the punchline: the more you tell them, the less they recall. And of course, accurate recall has a straight link or association with their safety. So helping them recall information is absolutely critical to their quality of care and their safety. I'm just going to mention some frameworks and tools or acronyms because there's a ton of them. We could fill up hours, but I just want to give you a broad idea. So the one I've used most in most medical schools in Europe, New Zealand, Australia, is the Calgary Cambridge, developed by a dear colleague and mentor of mine, Jonathan Silverman, and colleagues. And this is what we use at the medic school I teach at. And through every little step, there's an evidence base, this idea that you're moving between providing structure and building the relationship. And that throughout all these steps, there are key micro skills, little skills with an evidence base to support them. And part of the epiphany for me is that I didn't get any of this teaching. I was told what to find out, which is the content, but I was not told the skills, the process skills about how to find them out in different people with different emotional states. And I was certainly not encouraged to use my perception of adapting my approach depending on the person in front of me, their literacy, their numeracy, their culture, their belief systems, the verbal or non-verbal cues you're getting. All of those things means you need to dynamically adapt in the moment with the person or people in front of you. And this is equally important for colleagues. So this is the disease illness model. I've quoted 84, but in fact, it's probably the late 70s where a bunch of Canadian GP, primary care physicians, started thinking about that the focus had got very biomedical. It was all about symptoms and signs, investigations, pathology, and differential diagnosis. And it did not incorporate what people felt themselves was going on. In other words, if they arrived with a sore back and thought they might have a spinal tumor, and just reassuring them is not going to work. What their concerns are, what their lived experiences are. If they'd had a uncle who indeed did have a spinal tumor. That's going to influence their belief systems. And of course, the effects of the illness on their life. Have they lost their job? Has it had an impact on their relationship? Has it altered their faith indeed? So you need to integrate these two. And what we know is that skilled clinicians that incorporate both of these form much better connections. And as a result of those much better connections, patients and families disclose vital information that helps us shape their care, gets them the right care. And that brings us to strong emotions. And basically, if you look at many publications in this area, most difficult conversations have at their heart an emotive part of it that makes it hard. And people avoid conversations that are going to bring up strong emotions. And prognosis or advanced care planning, there's a bunch of them, existential issues. And if you do not feel confident, you avoid them. That has been studied time and time again. So again, just a reflection. Here's a face. It's one of the professional actors that we work with. And I want you to think, what emotion is this person experiencing? And would you regard it as mild, moderate, or severe? And I think if I got you all to put it in the chat, what we've done when we've done this exercise numerous times is that you all perceive different things, even though it's the same facial experience image. And that means that we form hypotheses about nonverbal cues, but like anything as a hypothesis, you need the skills to be able to check it. Is she feeling frustrated? Is she feeling distrustful? Is she angry? And we need to have the skills and the courage and confidence to check that out. So here's some colleagues from the US who have a group called Vital Talk, and they use this acronym as a way of dealing with strong emotions, and that you can choose one of these approaches in the moment. These are these micro skills. The idea of saying, I'm sensing that this has been quite overwhelming to hear about this scan. That's a naming skill. You have named, or I'll come back to normalizing in a minute, or that you can say, I'm sensing there are a lot of strong emotions. What is your biggest concern? And I'm always surprised and shocked that the thing I assume is upsetting them may not be the thing that's actually upsetting them. It may not be about their mortality. It may be about the care of their family, or another fear that you could never know based on lived experience. Silent support in summary, but probably the biggest thing is this idea of explicit empathy. Often we have a cognitive roadmap of what it might be like to be in their shoes, but we do not convey or show them, so they do not think we're as empathic as we think we are, because we're thinking the empathy but without showing it to them. Here's a graphic of a so-called anger wheel. And what I want to say about anger in particular is that it challenges our neurobiology, because when somebody's angry to us as clinicians, we have a fight, flight, or fear response. And that makes it very difficult to stay curious. And what we know, one of the best ways of de-escalating anger is to show the person we have heard why they're angry. So I've heard that this test has been cancelled 3 times, and you've been waiting in the outpatients for 2 hours, and that you're up all night in pain. If you can show them that you've heard why they're angry, it often rapidly changes their anger, and in fact often moves them to vulnerability, fear, or sadness. Here's a micro skill, normalizing for the population. This is a skill to show somebody they're not alone. A lot of people who have just heard about a scan with unexpected results can feel overwhelmed or frightened or unsure what that means of treatment, or even fear for the future. It's using your skills and experience to normalize their experience, and often they will give you non-verbal cues about where they fit. Yes, it's about fear, about future. No, I didn't really understand when the oncologist told me about my scan, but I was too embarrassed to ask. And by the way, right around the world, people are very worried about looking silly or stupid in front of highly educated health professionals. And often if you ask the question, have you got any questions? They say no, when they actually mean yes. And just changing that to, what questions do you have for me about the scan? It's an inference that you expect questions, and they'll often have a lot of courage to then say, I didn't understand what you meant by the nodes or whatever. So the other thing we know is when people are upset, the evidence is what the clinicians mostly do, they provide more medical information or health information. So don't respond to feelings with information or facts first. Acknowledge their emotion, validate their emotion, because when they're in an emotional channel, we know people that are emotionally aroused, it decreases their recall and their cognitive ability. You're wasting your time giving them more medical information until their emotions have settled down. How often have you heard, I didn't hear that at the time, even though they told me that? They were too upset. So you need to wait and deal with their emotions before providing more information. I'm going to quickly go on. Here is the original study, which is 50 years old, from education, in fact, showing that if you just wait 5 seconds after you ask a question, you're much more likely to get information and a lot more variation of information. This, in fact, this original study was in primary school education, and that has been replicated for 50 years in health. So the next time you see somebody who's vulnerable, ask a question and then internally count for 5. You'll be surprised how many times when you get to 4 or 5 seconds, they ask a really big, important question. And this is particularly true for those with less confidence or less agency, those disadvantaged cohorts. Cue spotting. What do I mean a cue? These are when people give us hints or clues or cues, and they can be verbal, something they said, oh yeah, I remember that, or oh, and they do something with their face. So they can be non-verbal or verbal. And this is Wendy Levinson's work from Boston in the US, showing that clinicians miss most cues. In fact, people give us cues about once or twice per minute. The good news is, if it's an important cue, might be concerned about finances or money or employment, they repeat them 2 or 3 times. And clinicians who pick them up and said, oh, I've heard you're concerned about your employment, let's deal with that in 5 or 10 minutes because it's really important. People then listen to you and you become much more time efficient. So it helps them and it helps you. But we do miss them. But if you spot and respond, you become more time efficient. What about nursing? Well, sadly, most of the research over the last 50 years has focused on doctors for very good reasons. In a sense, I think there's been a real problem. But myself and some nursing colleagues have done various studies, and what we've found is that the issues are remarkably similar, including how they actually can, how they talk to, between their professional groups, between doctors and nurses. But it's the same thing: complex family issues, and of course, issues around end of life. But if you do give professional development to those senior nurses, this is one about giving them more professional development, having goals of care conversations. They do it more often. They feel more confident, therefore they do it. This is the serious illness program. And what I want to say is it's a relatively modest amount of professional development, but look at the impact between the clinicians who had the professional development and those that did not. And my question to you is, if this was a drug, would we be prescribing it? Because the clinicians who had the skills meant the patients had less anxiety, less depression, more conversations about values, goals, prognosis, preferences, and end-of-life planning. They had them twice as early, 5 months before death rather than a few months before death. And all of that led to much more documentation in the electronic medical record. So if you invest in professional development in this space, it has huge benefits for the patients. I'll come back to the clinicians in a minute or two. Prognostic discordance. This is a term to say what the person thinks this illness means for the future and what the doctors or the clinical and the nurses and the clinical teams think is different. And this has been studied. I could have put up literally 100 papers on this. So first of all, what's been really interesting is right across cultures, they're increasingly similar, whether it's Korea, Japan, US, UK, New Zealand, Australia. And they want the doctor to be realistic. They do want us to incorporate hope, which again I'll come back to. They want individualized recommendations, and they do want our expertise. And in fact, in the concept of shared decision making, the thing we're not doing is giving them an individualized recommendation based on what you tell me about your family and your belief system and what's important to you. This is what I'd recommend we do next. They want that from us, but not a generic one, an individualized one. So here's people with metastatic cancer. It's from the US, and over half of them thought they were still had the possibility of cure. And I'm going to talk about these tools or micro skills that help avoid this chunking and checking, using cues, using this technique called teach back, etc. And it seems to be that certain ethnic minorities are even more prone to having this prognostic discordance between what their prognosis really is and what they think it is. People want these discussions about their prognosis, about end of life, and about accessing specialist palliative care. And again, the call outs or the graphics in the middle are about responding to emotions, saying how you signpost or structure consultations. But as you can see, 70% of the time, there's a significant discordance between what the oncologist thought their prognosis was and what the patient thought their prognosis was. And 90% of the time, the patients were not aware there was a difference between their cancer doctor and themselves. And look at that, nearly 100% of the time, the patients were vastly more optimistic about what their prognosis was. This still happens in palliative care all the time because people are implicit, not explicit and clear. So here's a little graphic I want you to think about. If you use Walter Beale's old spikes model about how to break bad news, in the thousands, in fact, probably tens of thousands of clinicians that I've worked with, the area they consistently underdo is checking what the patient really knows, what they really think it means from a whole range of skills. So persist with the perception checking before you give any news. The reason that people get into strife is they rush into giving the news without understanding what they already know. So it's a key, this idea of gather information before you give anything, even in the setting when they're quite anxious. Vary your styles. Use this ICE framework, what the patient believes, what they're concerned, what they expect. Link it to their past medical history. So this is the third line of immunotherapy you've had. How did that go? How do you think you're going? Not surprisingly, if they don't have a clear, true understanding of their prognosis, they make choices that are not concordant with their goals. So how often do you see people having another line of treatment? You think, well, that doesn't seem to fit with them wanting to spend time with their family or not spend so much time in hospital. And there are very clear evidence-based techniques like best, worst, and likely case scenario or a cohort model. If 100 people like you progressed over the next 6 months, this is might how it look like. Those are skills you need to practice. But what I'm saying is there's an evidence-based approach. And I think goal concordance will become an increasing metric of quality care. Here's just a slide to show that if you're skilled in delivering even very bad news, it does not seem to affect hope. This is the Hearth Hope Index, but it does require the clinician to be skilled. When do patients bring up these big questions about their future? Well, there's some numerous studies that show if you simply say at the start of meeting them, I'd like to talk to you about your kind of how you've got on with the morphine or the opioids since we started for your abdominal pain. We've got about 20 minutes. What's the most important thing you'd like to ask me about? So in other words, you tell them what you want to talk about, but you find out what they want to talk about. If you pause at that point They often have the courage to say, "Doctor, I'm really not sure this is working for me. I think I'm getting sicker. I don't know what to tell my family." Whatever it is, they bring up those big questions. Now, if you do that, so this is a study showed that only 3% of people coming into an acute hospital had anybody ask them what's important. But if you actually ask them, they didn't find it stressful. They leave hospital sooner. They clarify that they often don't want very burdensome, complex interventions, and they don't come back to hospital as much. So it works for them and it works for our health system. But you need to ask them early in the and I've done other studies looking at this as well, and they find exactly the same thing. I'm going to quickly talk about Greg McCool, who's got a tool where he asks patients how we communicate. And he's done, these are the questions. I'm not going to link in those, but what I want to show you is that he's done it in 20,000 patients in 20 different countries, and consistently, don't look to be too distracted by the numbers on the right. The three outliers that we don't check that they understood, we don't encourage them to ask questions, and we don't involve them in the decisions about their care. That's been consistent over decades across many different countries. This is a colleague, Ron Epstein from the US. And what I want to show here is he's used artificial intelligence to show if you give big chunks of information they don't understand. I could show you this paper in detail. It's fascinating. But what he showed is if you say a little bit and then they say a little bit, rather than big chunks, they're much more likely to understand their prognosis. And it's not about how much people talk, it's turn taking, that you need to say a little bit and then get them to say a little bit. So it's absolutely fascinating that they've been able to do this in a quantitative way using artificial intelligence. The words you use are important. So terms like non-compliant or your tests are bad, rather than they're outside the range and we're concerned what that means for you. How you choose your words is feeling very important. This is a diabetic colleague where they've used things like bad blood sugars and non-compliant. I want to quickly talk to you about us, our workforce, because we know that cancer clinicians have huge rates of burnout. And then I'm going to stop and take some questions. This is Catherine Pollock, and what she did is give coaching to palliative care and oncology clinicians. And she presented this at Southern Denmark and has kindly lent me the slides, like Ron and Gregory. And what she discovered is that people who got coaching felt less burnt out. They've got more energy, they stay fresh, they're able to give to their colleagues and their patients and their families. And it has impacts on the system, because the people who got coaching, the patients there had less hospital admissions, less unplanned readmissions, more palliative care input, more hospice input. So having these skills is beneficial for the system and beneficial for the clinician. I just want to mention incivility. This is the landmark paper from the Business Harvard Review in 2013. And this is to show that if somebody's been incivil to you, a colleague, these are all the things that happen to you. And by the way, I've provided the handout to your colleagues in Hospice Malaysia. Though I can't share some of my colleagues' slides, I'll share my own. So what you can see is that if somebody is rude or incivil to you, has a major impact on your own performance.